Well, welcome to this presentation on the history and practice of manual and manipulative therapy. I have been very fortunate to have been born at a time and to have come into physical therapy and to witness the evolution of this practice in our field. For when I started as a physiotherapist in New Zealand in 1958, manipulation was not part of our practice. Not in New Zealand, not in Australia, not in the United States, not anywhere, perhaps with the exception of one or two people in Norway. It was, of course, the practice of chiropractors, and to a lesser extent, osteopathic physicians, and a few medical physicians. In England, there were people like Syriacs teaching physiotherapists at one hospital, and there were many leaders developing in the medical field, such as Syriacs, Stoddard, Jean-Thierry Meeg, and Manel, all of whom are now deceased, all of whom I knew quite well. I stayed at the homes of 3 of those people, and 3 stayed at my place. The physical therapists who were about to shape the future of this field were beginning at that time. They were Maitland in Australia, and they were Carlton-born of Norway. And there'd be others to follow. Besides myself, there would later come in New Zealand, Mackenzie and Mulligan. Australia, there'd be Alvey. South America, from Chile, there'd be Roccabado. And finally, eventually, beginning in about the 1980s, the Americans began to put their stamp on this field. So I have witnessed from the time when manipulation was not practiced by physical therapists to where today it's part and parcel of this profession, a requirement under CAPTE. I've been privileged to be part of that movement, having led much of it, founding the orthopedic section, founding IFOMT, and of course founding this university, which, as you know, is closely associated and recognized as a leader in manual therapy. So with that as an introduction to you, let me now begin going through these slides and showing you what I have prepared for this presentation. These are the parts of the program I will cover: a history of manipulation, then its rebirth in America, because it's important for us to realize, at least politically, that when we began in the 1920s, there was manipulation being taught in this country. And then it died out, and I'll try and explain to you why. So then we had the rebirth of it. That began in the 1960s. We're going to be talking about this university. And then, of course, the topic, manipulation, mobilization, will, for the purpose of this presentation, be defined for you. We'll then look at the evidence, briefly, some of the early evidence supporting this work. And then, of course, the philosophy that we aspire to. We'll mention instability because it's often a forgotten factor, particularly now with people doing generalized techniques rather than specific techniques. They're forgetting about instabilities. And then we'll come to the conclusion. Firstly, the early history. No doubt backache has been with man since the very beginning. It's hard to think of not having had backache. If any joint can ache, the back seems to be that link. Whether it's evolutionary or whether it's just the way we happen to have been created, I'll leave that for you to decide. But right from the very beginning, manipulation seemed to play a role. Now this is 2500 BC. It is a statue in Thailand. And any way you look at that, something is being done to the right sacroiliac joint. And it looks like a forward torsion strain. So I would suspect back then even there were people who learned to touch others and massage, to push, to pull, to stretch, sometimes to click a bone. Sometimes they thought they were putting it back in place. But they would get a reputation as helping people, and so the practice of manipulation has just been indigenous to almost every culture around. We associate, however, Hippocrates, well known as the father of medicine, with the first person to speak about it, to record it, and to have a number of illustrations of him performing it. I like to think of him as the father of physical therapy, because much of what he did back then was physical therapy, not medicine. He used traction, as you can see here. And I'll go to the slide. You can notice that the patient is under traction. These levers here are going to be pulling strongly at each end. And while the patient's under traction, he's manipulating the vertebra. You'll see that type of thing repeated over and over again in the history. If that wasn't sufficient, he would put on his uniform and mount the patient under traction and walk on his back. Now, this is still practiced in places like Malaysia and Thailand, and I've had it done on my back by a young lady. I hasten to add it was done at a Hilton hotel, just so you know. But it was very relaxing to have her inch her body up my spine, digging her toes in at each level, and relaxing, my back with that. She was standing between two parallel bars, supporting her balance while she was doing that on my oiled back. Very pleasant. What's interesting in many of these early techniques is that they undressed for the performance. Typically it was the patient who undressed, and I think that was to stop them running away, because they were also frequently tied down. Not quite sure of the technique here. Hippocrates, we're back to here, is shown here massaging a shoulder joint. And he treated a lot of people from different sporting arenas, such as gladiators and that, and he would frequently put back their shoulders and sometimes use hot needles, hot pokers, to cause scarring of the tissues in the axilla to stabilize the shoulder joint if it repeatedly dislocated. No anesthetic in those days. They used alcohol, of course. Again, you can't run away when you're drunk, and your muscles are relaxed, and the pain is less noticeable. So alcohol was commonly used as an anesthetic. This is a classic technique of his, and I'd like to take a moment or two to show you the forces that are being applied. The patient has got a dislocated shoulder at the glenohumeral. We don't know whether that head of the humerus is anterior or posterior to the scapula. Even with an X-ray, it's often hard to tell. It doesn't really matter for the technique. You put the lateral border of the foot up against the neck of the scapula, so you sharply supinate your ankle. Then you pull down on the arm here, because what you're pulling against is all the muscle guarding that's taking place in response to the pain in this area and the damage. Someone pulls out like that to get it out so it can then locate itself back into the socket. Before he lets go, however, this person pulls strongly, brings the arm into the side so it leverages more over the foot. That helps this action, and then it's slowly released, and the tendency of nature is for it to pop back into place. I've done that on two occasions, once on a hockey field, field hockey, and once during a mountain climbing trip that I was on where one of our team dislocated their shoulder. He used up all my brandy in the process. Again, doing the shoulder. It's interesting to note that many of the people doing these techniques seem to realize that if you keep the elbow locked straight, as on a board, you cannot at the same time do much with the shoulder. With your elbow straight, a lot of the shoulder actions are stopped, because most shoulder actions begin with flexion of the elbow and come up through. But if your arm is held, it's unnatural for you to be able to do much in the shoulder. So they often tied it onto a board when they were wanting to do something in that area. TMJs. Obviously, they weren't exactly in this position, these operators, but the artist was commissioned to make sure he showed the faces of the performers. I can't quite figure out how this is secured, but it's traction again. And there are many illustrations like this in North African, Turkey, Europe, all being shown. Sometimes you must question why the board has to be so big, and so on. Getting more into the Middle Ages now, straightening out of joints like a tight knee. You can use an mechanical apparatus such as this, and more elaborate as a mechanical apparatus. Over a period of time, this cast bracing is still used today. But way back then, this was made by armorers, the people who made armaments for soldiers. And knights, they made these kinds of things. Now, I like this one in particular because at the right signal, she pulls the stool out. His arm is tied, so he can't do anything to defend himself. And the operator's going to sit down on that stick and get even more action. So they thought these things through, quite a performance. Guess which is the physical therapist and the physical therapist assistant? Ambrose Paré was the gentleman who coined the term orthopedics, which, as you know, means straight child. He also invented the physical therapy footstools, you might see, a very useful thing. There were bone setters developing, they were called that in Europe and in the United Kingdom. These are people who handed on the talent of doing these manipulations and straightening out of joints from father to son, from mother to daughter, ran in the families. You have to realize that back in these days, most joints that flared up and swelled were, of course, from trauma. But many were from tubercular joints, which were easily subject to injury from trauma. And so it was not able to distinguish who was tubercular and who was non-tubercular. The treatment of tubercular inflammation was to rest it. They sent people to sanatoriums for rest and recuperation. But the treatment for synovitis hemarthrosis is, of course, after a few days to get it moving again. Well, consequently, they treated everything conservatively in the medical profession. All injured, swollen joints were treated with rest. Many joints finished up stiff. It was the bone setters who treated them. They had a lot of work to do once they distinguished that it was not going to be a tubercular joint. Mad Sally, as she was called, was very famous and treated royalty in England. She was a bone setter. But this was the first bone setter to be knighted by King George V for his service to the royal family. So they were very respectable in society. His name is Sir Herbert Barker, and he was very much into footwear and had a shoe store in Regent Street. He died 5 years before I arrived in London, but I went to his shoe store and bought the best pair of shoes I have ever purchased, and I still use them. I keep them for special occasions. Now, the beginning of modern manual medicine and therapy. Warden Hood, 1870, that's a key date. This is a medical physician in England. It's a key date because it is before chiropractic and it is before osteopathy. And this was the first book to be published on manipulation. His father had treated an osteopath treated a bone setter by the name of Hutton. And he didn't charge Hutton for his services because he felt Hutton was doing a lot of good work in the community with his bone setting practice. So in response, Hutton said, well, let me teach you what I know. Well, Hood the elder couldn't take it up, but the young son, who just going through medical school, decided to learn how to manipulate joints from the bone setter. And so began this first book. And most of the techniques illustrated are on the extremities. The ones on the spine were described, but not illustrated, unfortunately. But there's some very good techniques there, and many of which are used today with different modifications. But it's important to realize that was the first book on manipulation, before modern chiropractic and osteopathy. Sir James Paget, a name you may know from Paget's disease, and a leading light in medicine in Britain, said, learn to imitate what is good and avoid what is bad in the practice of bone setters. Too long a rest, and remember I was referring to resting because of tuberculosis, is, I believe, by far the most frequent cause of delayed recovery after injury to joints. And not only to injured joints, but to those that have been kept at rest because parts near them have been injured. So learn from these bone setters. I think that's a fine piece of advice. And I took that when I came to America, and I learned from chiropractors. And I did learn from bone setters in England. Now they've died out. But I visited two of the last families in that connection. So Robert Jones is recognized as the father of British orthopedics, beginning really in the First World War. It was about the time that Mary McMillan was also an aide during the First World War, working with some of the Americans, but she also worked with Robert Jones, and had quite an influence on the founding of physiotherapy in this country. He said, we should mend our ways rather than abuse the unqualified. Now you're going to hear that many times in life, where someone says, oh, they're just this or they're just that. They're not qualified. Well, you know, if they're doing good things and getting good results, you should sometimes look at it. There might be something we need to pick up on. We mustn't be too closed. We are a very narrow, insulated, at times, profession. Dramatic success in their hands should cause us to inquire as to the reason. It is not wise nor dignified to waste time denouncing their mistakes, for we cannot hide the fact that their successes are our failures. I found that very powerful as a piece of influencing. It helped me open up to get beyond what I was taught by my instructors, because the day I graduated, they told me I now knew all I ever would need to know in physical therapy. They believed that. I didn't, and that's why I continue to learn. So now let's look at two phenomena that really began in America here. First, osteopathy. It came first. It was founded in 1874, July 22nd to be exact, by a medical physician by the name of Andrew Taylor Still. He had observed several of his family die from an outbreak of spinal meningitis, and the physicians of that time treated this with such things as bloodletting, leeches, and the giving of strychnine, a poison which is known to stimulate the body to help ward off other problems, such as in those days they'd also artificially raise your temperature to create an artificial high temperature such as an infection would do. He became, of course, very sad. 3 members of his family died from this, and being a religious man, he took himself off and meditated for a while. And he claims that on July 22nd, 1874, he had a divine revelation that he then knew the cause of all human disease and suffering. And he summed it up in what's known as the law of the artery. He said that the body will be at its best health if you have a good blood supply, and the quality of that blood is all that it can be. I think we should think about that for a moment. He's talking about nutrition, having good blood, and getting that blood supply to where it needs to be. That's what got him into mobilizing the viscera, massaging the viscera, the colon, the spleen, and also massaging joints and moving joints and muscles. He later took that further into the lymphatic system and became very keen that the lymphatic system was important to drain in order for the blood to be able to move through the tissues. So it was an advance, if you like, over medicine at the time. He did not turn his back on medicine. He just added to it the concept of good nutrition and good movement of the tissues, the law of the artery. Of course, he broke away from traditional medicine, had to set up his own medical school, which he did in Kirksville, Missouri, and he competed for years with medicine because he thought his concepts were better. But the osteopathic school in Missouri was very quick to embrace all the developments in medicine as they came along, including they was the first medical school to have an X-ray machine in 1897. This is the man, Andrew Taylor Still. He later wrote an autobiography, and I'm privileged to have one of those copies, one of the originals. And this, he says, is his first lesson in osteopathy. It occurred as a young boy, a teenager. He used to suffer very severe migraines. So he said. He never described the migraine, so I'm not sure it was just a bad headache or a migraine. Seems that it was a musculoskeletal headache, because the way he would seek relief was to leave the house, which was on the hot plains of Missouri, and go out under an oak tree for the shade. That would be the only cool place. There was not air conditioning in the 1850s or 60s when this took place. And he would lie down under the tree. One day he had visitors, and he was not permitted to leave the house as soon as the headache came on, but finally he had to, and he went out totally exhausted, fell down under the tree, and noted immediately that a root was digging into the back of his neck, just below the occiput. He was very, very uncomfortable, but too exhausted to move. Yet half a minute later, his headache had gone. And this we call today inhibitive distraction, if you like, but we know from many sources that pressure over the origin or insertion of a muscle will relax that muscle because of the Golgi tendon apparatus, something he had no idea of. But he, like many others, probably found this technique, and it worked for him. It relieved his headache. Hence, it was a musculoskeletal headache, far more likely than a migraine. Nonetheless, that was his first lesson in osteopathy. Osteopathy embraced medicine, kept to its roots. By 1928, the armed forces recognized this. Despite opposition of the American Medical Association, the armed forces gave osteopathic physicians equal rights with the medical MD profession within the armed forces. Now, one must be politically correct. Osteopaths are physicians. They are osteopathic physicians, DOs. Allopaths are physicians. They are allopathic physicians, MDs. So an MD is an allopath, A DO is an osteopath. Both are physicians. It would be incorrect to describe someone as a medical doctor and someone else as an osteopath. They are both medical doctors. So be careful on that one. Osteopaths would appreciate that consideration. 1874, osteopathy was founded. 1896, chiropractic, by D.D. Palmer. D.D. Palmer was a greengrocer and a magnetic healer. He would do healing part-time. One day he treated a janitor by the name of Harvey, manipulated somewhere in the upper thoracic area, around T2, it's believed. Never fully described, not even in his autobiography. Following which, Harvey's hearing, which had been almost totally lost, was completely restored. That's what's claimed, and that began chiropractic. In Davenport, Iowa, the school was founded, and he taught manipulation of the spine. He obviously studied it. We know that he went to Greece. We know that he traveled a little in Europe and met with bone setters before he really got going. But what really developed chiropractic was the son, B.J. Palmer. B.J. was a very charismatic individual, very much into communication, and established a radio station in Davenport, Iowa, and a college of communications before he moved in with his father and took over chiropractic school and promoted it. Now, that said, his father qualified him as a chiropractic at the age of 12. So much for that. But it was he who promoted chiropractic and spread it across the country to a great deal. Incidentally, he started to focus on the cervical spine, or cervical spine if you wish, but leaving the rest of the spine alone because, after all, everything passes through the cervical spine. Now, what I forgot to say is that what he was talking about was the law of the nerve. Whereas osteopathy had the law of the artery, chiropractic had the law of the nerve. And the law of the nerve simply states that the body will be at health at all times, provided the vital nerve force is intact. Now, the vital nerve force gets interfered with when the vertebra of the spine sublux, as can be seen in this illustration here. This vertebra is subluxed here, and here's a nice healthy nerve coming out of the foramen, totally filling it, and here it is being squeezed. So the vital nerve force is interfered. No matter that nerves never occupy more than a third of the foramen, and that this sort of situation has never been known to occur in modern history. But nonetheless, that illustration you'll still find on the walls of some chiropractic offices. It's easy to explain why you've got backache, Mrs. Jones, and why I must keep adjusting this into place. And it took a long time to get like that. It's going to take a long time and frequent revisits to keep it in place. You try and explain backache to your patients. It's much more difficult. This picture was taken in Florida, actually, in 1961 by myself. I found it amusing at the time, never thinking I would be here. Dr. Ellsworth E. Miller, chiropractor, in neon lights. That sort of thing was unheard of in those days, to advertise at all, other than a small plaque, but in neon lights. X-ray and physiotherapy. You see, in Florida, chiropractors were registered before physical therapists. And so in order for a physical therapist to get registered, they agreed to allow chiropractors to keep the name physiotherapy. Now, they can't say they're physiotherapists, but they can do physiotherapy. And then one day, we made a stupid mistake here in Florida. At when the Sunshine Act came up in the legislature, a physical therapist representing this profession, was asked by a legislator, is there any difference in the word physiotherapy and physical therapy? To which the physical therapist says, no, there's no difference. And from that day on in Florida, chiropractors are able to say they do physical therapy. So you need to be astute. You need to understand that there is competition, there is practice, territory to be protected. And the only way you should be protecting it is if it's in the best interest of the patient. And I think it is in the best interest to be transparent. But we lost something there. Over the years, chiropractic has split into two separate groups. They've become the straights and the mixers. The straights are those who stay to the theory that we've just been describing, the law of the nerve. But increasingly, chiropractors are reading the literature, are impressed by the modern world and know very well that the evidence points to far more than vertebrae being subluxed, pressing on nerves. In fact, there is little to no evidence for that. Advanced case of spondylolisthesis might be the exception. So they've begun to embrace the other areas, and they have moved, many of them, from talking about subluxations and adjustment to talking about movement disorders and manipulation, the position we're in. They have moved to our position. Their techniques have changed, their philosophy has changed, and like everybody in healthcare, they're embracing evidence-based practice. So they're going through quite a trauma. What is their future? On the one hand, the largest schools in this country, our chiropractic, are still teaching straight. But most schools now teach the mixed philosophy that I've just been describing to you. So they have two national associations which unite every time there's a legal battle in a state, but they are at loggerheads with one another. They want, of course, to become the primary care person's point of entry for the musculoskeletal system. So, of course, do we. Competition is healthy. Modern medical manipulation began with people like Monell, James Monell, around 1910. And then his son, John Monell, who succeeded him. And then James Syriax. There are many names there, but I mentioned before Sir James Paget telling us to learn to imitate what is good and avoid what is bad in the practice. And many a physician listened to that and took him up on it. A number of books started appearing on manipulation around 1910, 1920. They were done mainly by surgeons, and the patient was usually placed under anesthetic and once again undressed. Here's an extension technique. You can see once again this is a flexion technique meant to stretch out the spine. Nothing specific at all. They lacked a diagnosis. The patient had back pain. So manipulation might work if everything else failed. And so these are the ways they did it. With a relaxed patient, you could certainly get a good stretch. And you would set up a traumatic, inflammatory response. And if you manage that, you might in the process have corrected what was causing the back. Don't forget, many a patient has relieved their back pain by falling down a flight of stairs. Or even relieved their knee by falling and suddenly breaking an adhesion or something. So gross techniques were what was being practiced in those days. We know better now. The whole spine being rotated. This, of course, can be quite strenuous on the spine, and when the muscles are relaxed like this, it's under anesthesia, quite a stretch. Thomas Mallin, in 1934, published an excellent book, and he was the first to look at the mechanics of joints. He was before other names like Walmsley, before Kaltenborn, before anybody else, looking at the orientation of joints and thinking about which way the forces should be applied. He got some of it wrong by our concepts today, but he certainly tried to advance his understanding of this area. He used straps also. So now if you pull that foot or the leg into extension, that strap will tighten and it will manipulate, I think, in this case, the calcaneus. But that's what he would do. Years later, Kaltenborn would discover straps and think perhaps that he had founded that. But I caution you to think that there is very little that you'll ever come up with that's new, that hasn't been done by somebody else, somewhere else, and perhaps has died out for some reason or other, but may be rediscovered again. Traction, two-man technique once again, or three men actually. I think someone's pulling the arms, someone the legs, and he's manipulating a thoracic spine. He understood that you could get good traction on the shoulder joint if you push the elbow in, as long as you got a fulcrum in the axilla. And he did techniques to the thoracic and lumbar spines. And he did inhibitive distraction, which is where I first saw the technique. This book existed on my father's shelf. My father, being a physiotherapist, had a collection of books on manipulation, but no way to learn how to do the techniques. And he one day showed them to me when I was a student. He also compressed in this one, and I don't recommend it, the phrenic nerve to relieve hiccups. But the phrenic nerve also goes to other very important organs, and so I would suggest you don't practice this technique. So forget you've just seen it. James Monell wrote, and I love this statement, there is no magic about joint manipulation. When cure of symptoms occurs, it must be in accordance with the laws of anatomy, physiology, and psychology. If existing knowledge of the laws does not cover proven facts, the laws, must be extended. That makes sense to me. He also used extension techniques. He must have been quite a strong man, according to his son, who I met and who stayed with me for several weeks when I was living in Bermuda, and when he was writing a book there at my hotel. He was quite a strong man. He understood leverages. Here he's giving cervical traction by simply leaning down on his right arm, fulcruming on his thigh. That would then give good traction to the spine. Nice, easy way of applying it with the patient in sitting. He took the first x-rays that I've seen of manipulation, and he tried to show in this, though it's difficult to see, particularly on this reproduction here that you're looking at, that following a manipulation is a dark shadow in the joint. That's gas in the joint. Like x-rays of the bell will show gas in the bell. It'll show gas in the joint. And so he correctly said that when the joint clicks, he knew it is swollen, and he knew the muscles around it had relaxed. But he was also able to show that the swelling was not by some infusion of fluid, but it was indeed a gas bubble being formed. And he also timed it as to how long it would take before that gas bubble would be reabsorbed. 40 minutes was about a minimum, an hour was the average. So he did quite a bit of early thinking on this. When I was a young boy in physical therapy school, I used to go into a shoe shop on the weekends owned by an uncle of mine. In those days, shoe shop had x-ray machines that you could put your feet under and see whether your shoes fitted or not. I think it was more of a gimmick than anything else, because you can tell whether shoes fit or not. But anyhow, I on the weekends would anesthetize a sheep or two from the family farm, take them in and spend the weekend under that x-ray machine playing with joints, using dyes and everything else and so on, and then at the end of the day liberating a rather confused sheep. I've had a lot of x-rays exposure over the years, but no one ever thought that was a risk back then. Cyriax followed Manel. Cyriax is a genius in many ways. He wrote the best work that's ever been written on the extremities, the selective tension and diagnosis of hip and particularly shoulder problems, I think, remains unexcelled to this day. He could speak at least a dozen languages. He'd pick up on languages very quickly. Patients would come from all over Europe. He was very, very famous. He had a private practice on Wimpole Street next to Harley Street in London, but he gave 3 mornings a week, to St. Thomas's Hospital, where he worked pretty well virtually for free. He would examine 6 patients in a row, take the history of 6 patients. The history was all the same. He would insist on answers to what he was asking, and he would not look at you. And if you didn't answer him, he would just say Almoner, which meant social worker. The patient would be taken away and have to practice the questions with the social worker, and then in tears or whatever, then be brought back. He would do 10, 12 patients quite often, and then they'd go to 10, 12 cubicles. Then without taking a note with him, he'd go to those 10, 12 cubicles, examine those patients. By this time, I'm totally confused. I can't remember what patient came from where or what they had wrong with them. He's got it all in his head. And then he would sit down and he had his 12 cards, whatever the number was, and he'd fill out everything on each one of them, and he'd pass them to the physical therapist like that. And in 1 hour, he was sitting anywhere from 6 to 8 patients like that. And then he'd do that twice every morning, and then he'd just brusquely put on his coat and go without making eye contact with anybody. Quite an amazing person. In the years that followed, I got to see quite a bit of him. I married his chief physical therapist. I dated her to find out what was going on, and history's history. We debated. We had a wonderful debate in Spain once. He debating the disc as the primary cause of low back pain, my debating the facet. I responded to his work. He didn't pay mine any attention at all. He had such a narrow tunnel vision of what it was, but you couldn't help but admire him in many other ways. He looked like and acted like Alfred Hitchcock. You would not want to ask him a question, because if you did, that might be the only time he'd look up at you. He'd frown, and he'd say, "You haven't read my book." Page 165, second paragraph, volume 2. And he was right. because I would go look it up. And I was about the only one silly enough to ask him questions. And there's the Hitchcock picture I like of him. He saw things in very simple terms. If you had a sudden attack of low back pain or neck pain, you had torn your annulus, and that needed to be manipulated back into place. That was it. If the pain came on slowly and went below the buttock into the leg, what had happened is the nucleus had protruded out, and that would be sucked back with traction. Now, of course, they were the only cause of back pain. It was either a torn annulus, you manipulate, sudden contact, you manipulate. You're pretty safe doing that. But a more gradual onset going down the leg, you didn't manipulate, you gave traction. Also pretty safe. Two very safe rules. But of course, not all back pain is from the disc. There's also muscles, ligaments, sacroiliac joint, and of course facet joints, none of which would he accept other than this. His techniques were done under traction. As you can see here, again, traction being applied at both ends by a physical therapist, physiotherapist in England. And you can see there that while he's doing rotation, there's so much traction there, he's getting very little rotation. And so rotation might be safe in the presence of a disc. The rotation that the osteopathic physicians would do, and which you have learned in this school, would not be safe to a disc, because you're too specific and you don't have that protective traction that prevents the full range. So if you're in doubt, make sure you've got traction and not full rotation. He used extension again. And here's the cervical spine being manipulated. Now, I don't know exactly what James Syriac's weighed. He was not as tall as me, but he was much bigger, so he must have been over 200 pounds. And he would really stretch this. And if he helped the patient, he would say, there you are, we put the disc back. But I'm looking at facets being stretched, muscles being stretched, first rib being pulled down. I just don't see how you can use such a general technique and ever say what it is you think you have fixed at the end of it. You've not learnt anything from this technique. But of course, it may work. Transverse frictions. He was a very great believer in that, as am I. To restart the inflammatory action. Tennis elbows, for instance, are often chronic inflammatory conditions where an adhesion develops around the extensor mechanism. And every time you play tennis again, you trigger that adhesion, so it flares up once more. You either can break the adhesion with a manipulation, and there are manipulations for that, or you can stretch it out and start the healing process off again by transverse frictions. Both can sometimes be used. John Meynell. John Meynell, son of James Meynell, trained in England, moved to New Zealand, practiced there for a short time, moved to the United States, couldn't get a full medical license, as many foreign trained in this country have difficulty, especially back then, and worked for the VA system and taught some seminars to physiotherapists. I arrived in the United States in 1966. He'd been here 2 years prior to me, and we became fast friends, taught courses together. Here he is in 1979 in Atlanta, Georgia, at the opening of the Institute of Graduate Health Sciences, which today you know as the University of St. Augustine. He was present there to help with the official opening and the induction of the first class. We had 21 students in an advanced Masters of Health Science degree at the graduate level. Robert Mania is a name that you will not come across too often, but he's had quite an influence, especially in Europe. And he's very much against physical therapists doing manipulation, and has been instrumental in a number of ways in holding back the advance of physiotherapy in countries like France, where he was from. But he made a very good statement here, and I think it's very important to reflect on. Not everyone is able to practice manipulation, nor spend the necessary long time for self-training, or finding an adequate teacher, just as not everyone is able to play billiards or a musical instrument. And I think you need to reflect on that. And I put at the bottom of the slide this morning, you have a choice in physical therapy. You will learn manipulation in this school. But you don't have to specialize in it. You don't have to take it in the 7th semester, and you don't have to do it when you graduate. There are so many other areas of practice. Whereas if you went to chiropractic school, you don't have a choice. You may not be good at it, but the time you start practicing it, though, you're invested quite a way in terms of your courses you've taken, and now you'll probably stick it through, although you may never be very, very good at it. But I do think it's important to realize that not everyone will be good. Psychomotor skills of this nature are not in everyone's expertise. So do realize that, and use your colleagues if you're not one of those who has the proficiency or found the instructors to work with you. That's why residency training and fellowships are so important to develop those skills. His techniques were rather gross. Mostly, they went from one extreme to the other. These are quite strong techniques, as I say, and I would say they're gross. He's got the neck in the position here over the end of the table that I would certainly not recommend. If you had a vertebral artery incident, which is not uncommon, can happen, dizziness, whatever, how would you support that head? You better have a stool handy. But he also did oscillations. And it's understood that this is where Jeffrey Maitland, who went to Europe 2 years ahead of me. I went in 60, he was there in 58 studying. Jeffrey Maitland being from Australia. He may well have learned the oscillations from Mania. Mania didn't mind working with physical therapists in those days who came from other countries. He just wouldn't work with ones that came from France. And he worked with Roccabato and Maitland. I did not work with him. I worked with his partner, Jean-Thierry Meek. The time I was in Paris to study there for 2 or 3 months, Maine was in Algeria. At that time, France was at war in Algeria, and he'd been called up. Ellen Stoddard. This is a medical physician in Britain who went on to become a physical medicine specialist. Still not satisfied, he took the osteopathic training on top of it. He perhaps was the finest manipulator, the most gentle that I have ever met, most skilled. He was extremely helpful to me. We became very good friends. I spent a lot of time at his home. We went sailing a lot together. He taught me offshore sailing, and I taught 2 of his children to swim. He is a 4th generation vegetarian. He's now deceased, but I could say count him as a very close personal friend. He used spring testing techniques. Much of what you learned at the school came from him. In his 1959 book, the osteopathic technique, he called it. This is his daughter he is using as a model. She too is an osteopath, by the way. Has a practice in London now. For set lock. You'll learn that in thrust technique. The mid-lumbar technique that you know so well, that he was so good at, so gentle. He had me treating his patients in his clinic, and sometimes I would have difficulty getting the patient to relax sufficiently. If they were in discomfort, he'd just come along and they'd seem to melt in his hands. Of course, they knew he was the experienced one and I was the student, and I think you're going to have that problem too for a while. Patients won't relax quite so well for you when there's a senior person standing nearby that they have more confidence in. There are personalities in manual therapy, and you know a number of them. Kaltenborn from Norway, Maitland from Australia, myself from New Zealand and the United States, Gregory Grieve from United Kingdom, wrote some very fine books, deceased now. David Lamb from Canada, taught here quite often, the thrust course, deceased now. Brian Mulligan from New Zealand, Mackenzie from New Zealand, you've heard those names. Mariano Roccabato from Chile, and Elvie from Australia. You may not know his name, but he was the one who started neurotension that Butler continued on with and expanded beyond Elvie's comfort level with that field of work. Elvie is still with us, but not in good health. And neither is Maitland at this time. None of them, as you might notice, are from the United States. The United States hadn't really started. I won't say too much about each country, but Norway was perhaps one of the first countries where manipulation was being practiced by physical therapists, and it was led by Freddie Kaltenborn. There's a picture of Freddie Kaltenborn there at the signing of the IFOMT meeting, and it's Gregory Grieve alongside of him from England. I think there's something there I'd like to read to you. When Kaltenborn got a Doctor of Humane Letters, I got permission from the state of Florida to award Freddie Kaltenborn an honorary Doctor of Humane Letters from this university. I said of him at that time that he was the first clinical scientist in physiotherapy, for he knew that there was more to manipulation than just technique. He wanted to understand the arthrokinematics and apply that body of knowledge to his practice. Now think about this for a moment. What you're going to see is that chiropractors thought it was a vertebra out of place, traditionally. Osteopaths saw it as the law of the artery. Syriacs saw it as only the disc. Stoddard was more eclectic, saw it as the disc, the facet, and the sacroiliac. Kaltenborn stayed out of that argument. Kaltenborn said, I'll just normalize mechanics. If I normalize the function of a joint, that's the very best I can do. The rest of you can debate whether it's a bursitis or a tendonitis or this or that. I'm just going to fix the joint up for its function and give exercises. And that will be the best that I can do. As you know, in this school, we've entered the role of accepting the disc, the facet, the ligament, the muscle, the sacroiliac, and all of that, believing that if we can diagnose these things, difficult though it may be, we can more appropriately apply our treatments. That's our goal. Maitland stayed away from that also. He would not say what it is. He just did oscillations for the relief of pain and reproducible signs and symptoms. We're about the only school of thought that tries to address the actual diagnosis under the heading of syndromes. He avoided it. He was not the first to talk about convex concave, but he certainly was the first to bring it to our attention. And you know those rules. And he also was well aware of the arthrokinematics at the knee joint, that it consists of roll and slide as you extend the knee, but also that there's spin there, which you might call rotation. The knee, the tibia goes into external rotation, as you know, on the femur as you go into extension. So he was not trying to get knee extension by yanking on it to extension. He started to try and manipulate the arthrokinematics. He would try to reproduce the slide and the spin in his techniques, and that way enable you to go into extension. That was an advance over what anybody else had been doing before, with the possible exception of the doctor-physician Marlin in 1934. But Kaltenborn did not know of Marlin's work, by the way. He's illustrated this in a number of ways with his illustrations. He also gave us the classification of graded motion. I'm going to step into the camera for a moment. He talked about graded traction. When you lightly disengage a joint with traction 1, your PA glides are then a lot freer. If you go to traction 2, taking up the slack, your PA glides are very limited. So if you want to do PA to help either extension or flexion, you just want to get slightly into a grade 1 to unweight the joints. Don't go to a 2. Now if you want to stretch the capsule, then a grade 3 will be a stretch. So he gave us a simple numbering system, which is helpful. He was very precise, is very precise in his techniques. Here, not only is the patient tied down, but the scapula is fixed with that strap, because it's tight against the chest on both sides. The patient's not tied to the table. The strap is holding the scapula in place. So he can now pull on the humerus. And when he does, he steps back with his pelvis and back with his hands at the same time, so the distraction is pure, no flexion in it. And he would criticize you roundly if you had a little flexion in it. He was a very precise technician. In Australia, I mentioned the name Geoffrey Maitland. Here he is on the left with Dr. Catherine Patler and yours truly. Some years ago, you might notice. He's the gentleman who developed oscillations as techniques. This is 1974, and these pictures were taken. He came up with a grading system of oscillations, which means that a small amount of motion at the beginning of range of a joint is a grade 1, as shown. A larger range of motion in the middle of range is a grade 2. Now, neither of those go to the end of the range. Their only benefit can be physiological in terms of firing mechanoreceptors and perhaps having some muscular and maybe some minor lubricating effect on the joint. Grade 3 is a large motion thumping to the end of range. Not something we would do very often in the spine, but it's okay for the shoulder and the hip and the knee and the ankle, joints that can take quite a bit of force. A grade 4 is a very small motion at the end of range, coming up against the barrier. It's a gentle motion, but it's right at the end. And as that range increases under your thumbs, you might take it yet further. And we do use this in the spine, and you have learnt it in the cervical spine. If the range of motion is limited, as is shown here, they're having a pathological limit, the whole system is graded down. You're still working at that barrier, however. And as you push it back, then the system grades up again. It's a good system. Everyone uses it pretty well throughout the world. Uses his numbering system. You might notice he never used grade 5 anywhere. And grade 5 we often think of as a thrust technique in Maitland's concept. There's no grade 5 in his books or his writings. Bob Alvey is the gentleman who started neural tension. He noticed that straight leg raising, for instance, can change the range that you take the leg through based on whether the leg is an abduction or internal rotation. If you abduct slightly and externally rotate, you'll get more straight leg raising than if you keep the leg more central. And that had to bring that tension on the nerve. And so he started thinking about nerve root adhesions. The nerve is sensitive, yes, but when the disc protrusion gets the nerve, it becomes sensitive, but when the disc protrusion starts to shrink, it may leave behind adhesions that should be stretched, and many a manipulation technique has been devised for that, sometimes with good results, sometimes with very bad results. This way of freeing a nerve from its surrounds is much more gentle, and he developed that, and then along came others to do likewise. In New Zealand, Paris, McKenzie, Searle, and Mulligan are the names that have developed manipulation there. I went overseas in 1960-61, came back, and the first two people to attend my course was McKenzie and Mulligan. And then they got interested in this work, and they grew from that. Here's me in 1960 with Freddie Kaltenborn in Norway. This is a picture of the local newspaper. He made sure the press was there. This was his first overseas visitor. I was 23 years of age at the time. Years later, Kaltenborn and myself, and finally, when he was here getting his Doctor of Humane Letters, and you see our Dr. Gorniak, Freddie Kaltenborn, and myself. This is my book I published in 1965, which seemed to be a state secret for a while. But it did sell out eventually, and now I'm in the process finally that I've retired in rewriting my books. One of the things that I came up with then was a classification system which was a hybrid between what Stoddard had designed and what Kaltenborn had. They since both of them adopted it. It was just a simple little mathematical way of talking about the movement. And very quickly, if you examine joints and you decide that they have a normal range of movement, that's a 3. A 2 is a slight restriction, and you could use thrust or non-thrust techniques on that. A 1 is a considerable restriction, and you should be careful. If you do a thrust technique deliberately or inadvertently on a considerable restriction, you could tear it, create more problems, and be worse off. And then, of course, a 0 is fused, either surgically or congenitally, and you wouldn't do anything to that. Slight increase, there's no need to worry about it. That's what athletes have. That's what we'd all like. There's a little bit more motion. There's nothing to be concerned about. It may well follow a restriction, be just above a restriction, in which case you know it might get worse. But when it starts to give discomfort, that would be a grade 5. And I spoke of this way back in 1963 in my first ever published article in the New Zealand Medical Journal. I couldn't publish in the Physiotherapy Journal. They wouldn't accept anything on manipulation, but the Medical Journal in New Zealand did. And I spoke at their national conference, and that paper followed. So I talked then of stabilization, and that was mainly posture. We weren't talking about transverse abdominis and other muscles that the Australians seem to have got carried away with. And then finally 6, if our posture training and muscle tension training doesn't work, you may have to consider surgery to do the spine. But I was very keen on this whole concept of arthrokinematics. And I didn't think it was well understood, and nor do I think it's well understood today. I was influenced by a number of books, Marlin, a little bit from Kaltenborn, but particularly a book from Stanley here, a orthopedist at University of Iowa. He wrote a classic book on biomechanics, and talked about the biomechanics of every joint in terms of what we now know as component motions in joint place. And it was from that that I got the concept of component motions, a term that I think I came up with. But I want to explain to you and to the audience who's going to watch this video, I want to show you an explanation of Codman's paradox. In 1934, there was a orthopedic surgeon in Boston by the name of E.A. Codman. He wrote a book, The Shoulder. He was an orthopedic surgeon who specialized in the shoulder, but he was also a general orthopedist, as all were at that time. But he knew a great deal about arthrokinematics, and he explained something which has become known as Codman's paradox. If you watch now, my hand is by my side. As I raise my arm to there, it isn't obvious that I rotated my arm. Nor as I carry my arm back does it appear that I've rotated my arm. Nor as I lower it to my side would it appear that at any phase of those three motions did I rotate. But look, my hand is now facing forward. It did start there. Here, here, to there. I've gone through 90 degrees of rotation. So where is that rotation? Well, it's not here. It's all there. Between there and there is 90 degrees. And there's none here either. Now, you're taking my word for it, but let me try and show it to you. It isn't obvious that when I do that there's 90 degrees of rotation. But if I come down to here and do the same thing, now you can see it. You see it there now? Because here, I was just going like that. But here, I'm doing the same thing, finishing up in the same plane. It's all there. Now, we still test the shoulder for medical, legal reasons, this way and that way. Nobody ever does either of those motions. So I'm big into recognizing the value of diagonals. The body works on diagonals. It does not work on the sagittal and frontal plane. In fact, if you ever raise your arm, you raise it there. If something's in front of me, I don't reach like that for it. I'm more likely to reach like that for it. If it's to the side of me, I'll reach like that. Again, I'm always raising there. I don't throw stones like that any longer. If I'm going to throw a dart on a diagonal, I'm going to throw a rock, it can consist of several diagonals. Everything we do is on a diagonal. So, this is where you should measure abduction of the shoulder. It turns out that in this position, that's external rotation. That's neutral, that's internal. Now you can use this information. If you have a patient having difficulty abducting their arm here, but can do so more freely here, that limitation is not abduction in the frontal plane. True, it was. But the real answer is external rotation. They're lacking external rotation, and that's what you would treat. So it's fine to examine this way and this way, but you should also do that way. The body functions on diagonals. Diagonals are important not just for skilled motions and for everyday function, but even when you're doing strong activities. For instance, take this big object. Let's say it wasn't on wheels and I wanted to push it across the floor. The layperson would think that using both hands and both legs would give you the most strength. But in point of fact, I think most of you know that getting on a diagonal and pushing with one leg is actually stronger than pushing with two. So one leg on a diagonal is stronger than two on a straight plane. And while weightlifters may go down like that to pick up the weight in a straight pattern, that's because they have to. There's a bar holding those two weights. There's no other way. But most of us going down to lift would get the object like this and come up on a diagonal. And going down for a light object, you don't bend like that for it. You'd probably go down like that for that object, always on a diagonal. That's the way the body functions. We must examine it in that way, as well as the straight patterns, because the differences can be helpful. Robert Mackenzie, a New Zealander, as well known internationally, perhaps the world's most well-known physiotherapist in many ways, because of his Mackenzie method and all the books that he's published on his techniques. His techniques really involve repetitive motion. He was a student of mine and then studied with Carlton Bourne in Norway and then assisted Carlton Bourne in his teachings in New Zealand and Australia for a while. But one day Mackenzie had a little incident in his clinic where a man who had come in bent over, unable to straighten up, was told, and it was the second visit of this gentleman, he was told to go and lie up on the treatment table in the cubicle there, as he had done the previous day. The problem was someone had raised the end of the treatment table up, and so instead of being horizontal, it was now raised up. But the man got up there, face down, on this table, and he had not been able to straighten up. But when Mackenzie came back in some 20 minutes later, being delayed for various reasons, the man's lordosis had returned, and he was able to stand up straight. And that had Mackenzie thinking, what is it that occurred in this incident that I could use in the future on patients who are bent over and can't stand up? And so he got very much into trying to understand extension. He noticed that Manel and others had used extension over the years. He found you can't immediately extend a patient, but if you try repetitively, you can. And so he also noticed that it would work well and cause no harm if the pain didn't spread when you were doing this. In fact, he noticed the pain often centralized. So just as Codman found at the shoulder that if you did back and forth and to and fro motions to the shoulder, that you could centralize shoulder pain, Mackenzie found that he could centralize low back pain with repetitive motion. He, of course, assumed that he was putting the disc back into place, because that was what he felt he was doing. And still to this day, a lot of people would kind of associate the centralization of leg and low back pain, or leg pain back into the lumbar spine, as centralizing the disc. But we know better. With MRIs and CT scans, no one has ever replaced the disc. Not with manipulation, not with traction, not with Mackenzie. Once the nucleus comes out, it will swell to 2 to 3 times its enclosed size. While it can be moved around, it cannot be put back. There's too much pressure in the disc, and there's no way you can get a force around that nucleus to put it in. Even if you could get your thumbs in there, I don't think you could get it back in the tear which it came out. Brian Mulligan, also a New Zealander, has made quite a name for himself in the 1990s and into the 21st century, using manual therapy techniques very much along the lines that I do and Carlton Bourne, but doing them with movement. As he, for instance, tries to manipulate right rotation in the upper thoracic area, he'll have the patient turn to the right at the same time. Some of us have done that before he started making a big thing of it and studying it in depth, but he has explored it and developed a number of techniques along those lines, and they're very effective and have been shown to be in the literature. So having the patient help you to manipulate their joints in terms of the skilled passive movement is a therapeutic advantage. In Canada, that country to the north of us that we sometimes forget about, has had many a fine manipulator, including David Lamb and Cliff Fowler, and I've mentioned David Lamb to you before. Here is David Lamb. He was an international speaker, Englishman, born there, but worked in Canada quite a while. Here with Freddie Carlton Bourne in Spain, where we had a number of seminars in the Canary Islands for years, bringing different people together so we could share our techniques. That's one thing that's very interesting in manual therapy. We've got together to share our techniques and our practice. Then in South America, Mariano Rocabardo, a physical therapist whose sister was a dentist. And one day, while in physical therapy school, his sister said, what are you learning about the TMJ joint? What is it that you physical therapists can do? He went to his instructors and learned that there was nothing he would be taught on the TMJ joint during his training. So that began his interest in that area, and he rose to become a full professor at dental school. And of course he teaches throughout the world, and he is now the dean, if you like, over the schools of physical therapy, occupational therapy, and dietetics at Andres Bello University in Santiago, Chile. Rebirth in America. If we look carefully at the American history of physical therapy, which I did for the purpose of my Mary McMillan address, I knew it, but I found out even more so by looking at all the literature, our early journals and everything, that we were from the very beginning practicing joint manipulation in this country in the 1920s. But that would all change. That would all change with chiropractic. We were always short of physical therapists, so we didn't seem to mind giving up an area of practice. And when chiropractors started promoting manipulation to the extent that they did, that it could cure everything, They started to give manipulation a bad name, and so physical therapists backed away from it. And the point I make here now is not only do we lose manipulation, but we have failed in this country to pick up many areas of practice that we are only now beginning to look at. The year now is February 2009, and your National Association is taking this pretty seriously. They're having a number of retreats. I've just been to one, the Graham sessions, where there are think tanks on the future of physical therapy. There are more coming up this year, 2 more. What we are aware of in this country is that in New Zealand, for instance, physical therapists have direct access. They can order x-rays, and they can refer patients to doctors, and the report will come back to them, the physical therapist. In Australia, likewise. In England, not only do they have direct access and can refer for x-rays, they can also prescribe pharmaceuticals, a limited number, and they can also give soft tissue injections, muscles, tendons, and joints. Now, the authority to do these things is usually with an additional postgraduate certification, of course, and only to experienced therapists, 2 or 3 years, and then you can take the testing. These countries have moved ahead of the United States. Not only that, they have a broader scope of practice. Because we have been chronically short of physical therapists in America, chronically short, we have not met the need. We lost the area of athletics, largely, to athletic trainers. They don't exist elsewhere. We lost acupuncture, despite the fact that people like myself were using acupuncture in the early 1970s. We lost it by state laws to acupuncture. Now it's a separate profession. Whereas it should be a modality within our profession, freely available on the occasion that it's needed, you have to go outside of this to a person who naturally has this as their only tool, will apply it far too broadly. But in England, Canada, Australia, New Zealand, you can do acupuncture. Again, certification required. We've lost pre- and postnatal care. We lost cardiopulmonary to respiratory therapists, all through our chronic shortage. So I'm one of those who's not concerned about an occasional oversupply. I hope one is not coming. It's hard to get through them, but it makes us all think about our quality, and it does expand our practice. We say we are the wellness profession, but where's the incentive for you to get into wellness if you're busily employed wherever you are without fear of loss of your job? So anyhow, our profession at the national level, APTA, is now taking it seriously and is trying to forge this. We believe that that's the best way to beat POPs and all the other kinds of things, is to go at the big picture and use the experience of other countries. Many people from other countries are coming to this country in October in one of these forums that I mentioned, and I believe I'll be privileged to be present at that. Well, back to our early history. We were manipulating in the 1921s. It says here, if you read 1921, writing on physiotherapy and stiff and painful shoulder, Granger stated that on forceful manipulation is found that the scapula moves coincidentally, and so on and so on. And here in the book by Mary Macmillan, our founder, the last paragraph there, manipulation of muscles and joints, therapeutic exercise, electrotherapy, and hydrotherapy is what physiotherapy is all about. Back then we were called physiotherapists. So it's there from our beginning, and there are a number of references that make that very clear. And politically that's important, because there are other groups who would like to say we're only Johnny-come-latelys to this. But we come from medicine. We're an offshoot of medicine. Macmillan and the aides were aides in the First World War, trained by Sir Robert Jones and others. They brought their skills back to here, and physical therapy grew from as an offshoot of medicine. So they were doing it medicine before even chiropractic. And I've mentioned the history here, but very briefly, there was no manipulation done by physiotherapists in this country in 1961. It was a no-no. I was over here on a scholarship from New Zealand Workers' Compensation Board, and I went to the association headquarters then in New York and asked to be put in touch with physical therapists who manipulate. I was told in no uncertain terms, that is not part of your practice. I visited a certain physical therapist who later became the president of the APTA, and all he was doing for the spine was Williams flexion exercises in those days. No manipulation. 1963, John Monell arrived here. 1966, I arrived in Boston. I got the appointment as a faculty member at Boston University based on the strength that I had 3 publications and a book. I was 26 years of age at the time. But soon after I arrived, they apparently read my book or something. They didn't initially. They just looked at the resume, and they were scared that I wanted to teach manipulation. So the dean gave me this letter, which had 6 points. Here's one of the points. Shall not be permitted to teach, write, edit, or in any way be associated with spinal manipulation. Dean McKechnie, Boston University. I resigned the following day, but stayed for the 8 months. They needed me, and I needed the job. But they had my resignation. And I started my private practice within a month, and I was doing manipulation, and at Mass General Hospital. 1967, medicine that was opposing physical therapists doing manipulation in this country. They had a committee on quackery of the American Medical Association, hell-bent to put chiropractors out of business. They even investigated me. One of the members was the chief of, well, second chief of neurosurgery at Mass General Hospital. I came before the committee of quackery and went to Chicago to defend myself because I believed that I was doing medical manipulation and manipulation from physical therapy and osteopathy, and they couldn't hit osteopathy because, as you know, it was recognized by the United States government, so I was on safe ground. And I won my case. In other words, they stopped harassing me, I think. But they formed in 1967 the North American Academy of Manipulation Medicine. It was founded by John Monell and Janet Travell. Dr. Janet Travell, you may know Travell's trigger points. She was also but she was the physician to President John F. Kennedy. She was the White House physician. I wrote to her asking to be a member of the North American Academy of Manipulation Medicine, if not a full member, an associate member. And the response I got from her was that manipulation was a diagnostic and therapeutic tool that should be reserved for physicians only. And that letter was crafted by Robert Maine, who had come over for their founding meeting. Same year, I tried to set up a section on manipulation within the APTA, but was turned down. Eugene Michaels was then the president, and he was the gentleman that I had visited some years earlier on my travels here in 1961. So in 1968, on August the 25th, I set up in Boston the North American Academy of Manipulative Therapy. Here is a picture from that day. Seated is Marjorie Anta, the chief of physical therapy at Massachusetts General Hospital. She was in full support of my doing manipulation. She had told me that she didn't understand it, but I could do it if the doctors didn't mind it. But if I made a mistake, I was on my own. Fair enough. I gave a presentation, several presentations, but one day I gave a small one, and the doctor said to me, "I don't want you manipulating my patients." I said, "That's fine, sir. They're your patients. That's fine. But would you mind if I did skilled passive movement?" He said, "No, not at all." I just made sure that I didn't kick or pop a joint, but I certainly used manipulation on his patients, because we do skilled passive movements to a joint, and that's the definition that I published many times over the years. John Monell, seated on the right of the picture there. He certainly was a supporter of us, but he didn't believe that physical therapists should diagnose. He thought manipulation should always be prescribed by the doctor. So we did have our differences, of course. But he was very good in taking me to the American Osteopathic Association, forming an alliance with them, and getting my first article in America published in the Osteopathic Journal on how physical therapists working with osteopaths can spread the availability of manipulation. But the North American Academy of Manipulation Therapy grew to 900 and something members, 920 members, larger than any section of the APTA. So now with 920 members, I went to the APTA and I said, "You got a choice here. Either you admit us into the American Physical Therapy Association, or we're going to become a separate group. We'll get too big and too strong, and we won't want to join you." So we compromised. We founded the orthopedic section, which was a good idea. And I was the first president of that section. Here's the founding signing of the documents. The names are there, but I unfortunately don't know the name of the young lady seated, who was a staff member of APTA who brought the documents at the last moment, and I'm sorry her name is lost. But that was the day, 1974. The same week, and that was in Montreal, Canada, where, by the way, APTA held its annual conference in Canada at the time, along with the World Confederation. And the same week, I chaired the session that led to the founding of the International Federation of Orthopedic Manipulative Therapy. I had founded this committee 4 years earlier in Amsterdam, and seated on there is Jeffrey Maitland in Australia. He was a consultant. Freddie Kaltenborn, a consultant. Gregory Grieve, a consultant, and I was the chair, and the other members of the committee were Robert McKenzie of New Zealand, I represent the United States, and there was a young lady, Hannah Thorsen, from Denmark. That was the founding of IFOMT, which is now spread throughout the world, 26 member countries, a very successful organization. So the manipulation group in America disappeared. It folded into the orthopedic section, which we put in our charter from the very beginning. But now a problem developed. We had an international federation, IFOMT, but to be a member of IFOMT, you have to pass an exam. And there's no way that the orthopedic section, and it's only member bodies, it's not individuals can't be a member of IFOMT, only organizations. So the organization that's best spoke for manipulation in America would be the orthopedic section. But the standards committee of IFOMT said you have to have examination standards within the orthopedic section, or the orthopedic section cannot be a member of IFOMT. No section in APTA has examination standards. You can join the education section, the pediatric section, anything you want to, just by interest in paying the fee. So we set up the academy, the American Academy of Orthopedic Manipulative Therapy, a spin-off. We set that up with examination standards and then went to APTA for its recognition. So the orthopedic section certainly recognized it because we loaded that meeting, and then the APTA recognized it too because we're on the right track. And after that, we became a member of IFOMT. Small detail. Now the University of St. Augustine comes into this just a little bit. 1979 was really the beginning of this university because it was, at that time in Atlanta, I was probably the most active period of my life. I was 42. I'd founded the Atlanta Back Clinic, which grew to occupy 3 floors of a 7-floor hospital. Our last few months, we averaged 24 patients in hospital a day. We had 2 surgeons consulting their practices entirely with us, 3 physicians, 8 physical therapists, 5 psychologists, dietitians, drug counselors, Tai Chi instructors, lots of different people. It was a model. It was the first multidisciplinary back clinic in this country, and it was owned and run by a physical therapist. I was very proud of that. Same time, I had Southeastern clinics. That had a number of contracts with hospitals, nursing homes. We had the West Paces Ferry Headache and Facial Pain Clinic, which Mariana Roccabata conducted, the Back School of Atlanta, which Ron Porter conducted, and Clayton General Hospital was a large hospital which we provided all the therapy to as a private practice. I was in the middle of my doctoral studies in anatomy and biomechanics, and we founded at the same time the Institute. Some quick pictures on the Atlanta Back Clinic that come from our archives, our medical director, myself doing a manipulation there. We had our own radiology in our own department. We had psychology, as I mentioned. We had counseling and vocational counseling and job counseling. Biofeedback was one of the techniques we used for relaxation, muscle training. We were written up in Time magazine, Reader's Digest, and the New York Times. They all featured stories or feature a story on the back pain, and we would be mentioned once or twice in those. We were very making grounds. We had lots of people come to visit us, and they established their clinics, like the Plano, Texas clinic, which is now the largest in the country. In my doctoral studies, I was reputed to have discovered a nerve in the lumbar spine, which is correct. This is the ascending nerve here to the facet joint. It had never been described before. But coincidentally, this had 2, more usual just to have 1. And I found that's the facet joint there. I found it at other levels of the spine also. It's only a 0.5 millimeter thick. I flattened it for the purpose of the photograph, and here are the millimeter measurements there. But that was written up in Medical World News, and we got more funding and more cadavers, and it was a good time. This is the work that based on that, showing the innovation of the facet joint. That was the nerve I discovered. But we also were the first to describe these 2 nerves here, and to give a clear statement as to which way this recurrent nerve sinovertebralis may innervate the facet joint as well. It was believed only 2 nerves went to the facet. Time we finished, 5 nerves went to the facet. So at that time, our work in neuroanatomy, my work principally, was foremost in this country, and I did a lot of speaking to neurosurgical groups and others. I'm showing you their adhesions, as you know. The synovial facet joint was thought to believe just one small little cavity like that. We found a much larger, more centralized cavity, the medial component of that joint, and that was more innovative than the standard position. So little was known about spinal anatomy. So little is still known about spinal anatomy. that it was easy to make some difference there. So we founded the Institute in 1979. 1981 we started manual therapy certification. We also became accredited in 1991 by the Distance Education Training Council. 1994 we commenced an MPT degree and got accredited by CAPTE. Then we commenced the OT degree in 1996, and ACOTE accredited us. 1997 we became a university, 12 years ago. 2006 we began in Boca Raton, the online program, which I think you're familiar a little bit with. Has 26 students coming in this intake, so finally at a good functioning level. In 2007 we opened in San Diego. In 2009, 2010, anybody's guess. Right now our plans to open a school in New Zealand are on hold. We were quite advanced, really near to declaring it to open next year. But given to the financial crisis that confronts everybody right now, it's more important that we sit on our hands and play this one safe. So not taking any risks at present. Here's the picture in 1979, the founding of our group. I'm on the left there. Dr. John Manel's wife, Marjorie Ond from Massachusetts General Hospital, came to Atlanta. My wife at the time, and John Manel on the right. This is the faculty that I had in 1983. I had them all out in Vail, Colorado. We used to go out for 2 weeks every year and teach seminars there. We taught seminars all around the country. You probably know we have some 200 a year around the country. Sometimes we have motor vehicle accidents. This was an accident I had when a truck changed its mind about going across a bridge and badly damaged my car, but more so the trailer, so I had to get another trailer and offload all the supplies that go to our courses. This is returning from Vail, by the way. I also flew to courses. I'm a pilot. I later got a larger aircraft so I could carry all my tables and that too. That's my second son there. And we've even sailed to courses. We've taught about 10 in the Bahamas and about 5 in Bermuda. And there you can see Dr. Patler on your left and myself at the helm having a blast. And as you know, sailing is my sport, and it's a very expensive sport, and this is Stoddard's fault because he's the one who got me into training, as you know. When we started here on this campus, this is where we were, Flagler Hospital. We occupied a clinic downstairs, and where people like Beatty and Rott, others worked, did their fellowships, and upstairs we had the school. Here we are now, of course, and there's even more recent pictures. So know that today we are the first proprietary school of physical and of occupational therapy. We're one of the first to offer the DPT and, of course, the transitional DPT and the transitional OTD. And we're the only school to offer the dual degree. Our second campus is in San Diego, and we're the first to offer a full online DPT option, Boca Raton and now San Diego as well. And this year we'll also be back into offering the Doctor of Health Science and the EDD, mostly both of those online. Well, this completes the presentation on the history of manual therapy. What follows now, for those who are interested in seeing this piece, is the definitions of manipulation, mobilization, and some of the current schools of thought. This is other information that could be useful to you at this time, or you could gain at a later period. Manipulation, I defined in the Journal of American Physical Therapy Association in 1979, in the first article that had appeared for some time on this topic. I defined it as the skilled passive movement to a joint. Years later, the Guide to Physical Therapist Practice took that, as well as a lot of other input, and came out with a very secure medico-legal definition. It described manipulation, mobilization. You'll notice they're synonymous terms and should be used as such. A manual therapy technique comprising a continuum of skilled passive movements to the joint and or related soft tissues that are applied at varying speeds and amplitudes, including a small amplitude, high velocity therapeutic movement. Give some thought to that statement. It covers everything, covers the skilled passive movement to a joint, varying speeds and amplitudes. A very good medico-legal, unfortunately, difficult to remember. The definition of manual therapy, also difficult to remember, but should be read and understood. So I would, in speaking to a patient or anybody who asks, define manipulation as a skilled passive movement to a joint. That's the way I've done it for many years, but more recently, realizing that there are some skilled passive movements we do to joints, such as straight leg raising, which are not manipulations, the definition was therefore not quite correct. So now I've changed it to a skilled passive movement to a joint with a therapeutic intent. That, I think, is the easiest, most succinct definition, and I would encourage you to remember it. We manipulate a number of things, such as the adhesion here, just seen to the right of the forceps. I'm pulling on that so it can be seen. This was a joint on dissection that didn't have a great deal of motion, and had it been a living subject, our manipulations might have broken or stretched out this adhesion. Manipulations also can replace sublux joints. It's very clear here that there's a large separation of symphysis pubis, and over here a very small separation. On closer examination, it was the right sacroiliac on the same side as a tight hip. So no doubt in this male runner, orthopedic surgeon incidentally, the tight hip led to a hypermobile sacroiliac joint, and when riding a mechanical bull in Gillies Bar in Texas, he subluxed this joint. I manipulated it. A deep thud as it came back into position. Here, you can see it's closed down now, and held it together with a binder. That's the pin holding the binder together. He had a good recovery from that situation. That's enough for mechanical effects, but we also need to think about the neurophysiological and how we fire different types of mechanoreceptors. These mechanoreceptors no doubt function on the gait control mechanism and block onward transmission of nociception, in other words pain, and therefore prevent nociception getting to the brain where it's recognized as pain. So large fiber stimulation through oscillations, through Maitland's type technique or Codman or McKenzie can block the onward transmission of pain and have other beneficial advantages such as in moving joints and so on, helping in their nutrition and repair. An area that we have contributed considerably in, myself and Dr. Patler, is the classification of end fields, the sense of motion at the end of a range. If my arm gets as far as this, it should have a nice soft end field being the muscles here. But if that was a hard end field, it could be a capsule, it could be cartilage on cartilage, it could be a number of abnormal end fields, and we would need to differentiate between them, and that would help us in selecting our treatments. For years, manipulation was done because people said it worked. Chiropractors, osteopaths, medical doctors, physical therapists, and others, bone setters. As to the evidence, the big breakthrough came in 1996. Up until this time, we weren't really being requested to have evidence in medicine and physical therapy for the things that we did. But the Agency of Healthcare Policy and Research looked at all the literature having to do with low back pain, both acute and chronic, and tried to develop, and did develop, some guidelines, which it then published. And looking at some 22,000 articles, the agencies and its consultants, consisting of osteopaths, chiropractors, physical therapists, doctors, statisticians, sociologists, everybody you can think of on the panel, decided from looking at the literature, weighing its strengths and weaknesses, that of value for the treatment of low back pain, acute low back pain, was exercises and postural instruction and manipulation. Of limited value, medications. Of no value, physical therapy and bed rest. Now you may wonder what physical therapy is doing down there. Well, in many of the studies, physical therapy was a hot pack or an ultrasound machine or a detuned short wave. Of course, our profession objected to that, and we now hope that the word physical therapy won't be used for the control or the placebo. But look at what was of value. Exercises and postural instruction and manipulation, and that's physical therapy more than any other profession. This was the first of the guidelines and announcements and evidence that supported our practice, and we felt very relieved to see that. There have been many studies since. Here are some of them, and beginning with 1995 and going to 2003. Since 2003, there's been a veritable explosion of evidence supporting manipulation. And rather than list all those articles, I'd leave it to the individual instructor to choose the ones they wish to present to you. We must also look at the competition that exists for the patient between the orthopedic surgeon, who has a predilection to do surgery, and the physical therapist, who would prefer to do physical therapy. There was an excellent study in 2003 looking at patients who had clearly neurological complications to their low back pain. And these were patients, of course, that in many cases would have surgery. But in this particular instance, they were not given surgery, but rather it was decided by the studies and the papers that have been published, because this was looking at a number of papers. There were 30 authors on this particular paper. It was a meta-analysis of the current literature, that paresis, and as you know that's muscle weakness, paresis, though serious, does not require immediate surgery. Just wait 2 months. That conservative management, which is medical and usually sometimes physical therapy, is equal to or better than surgery for low back pain. Both groups get a 70% result, conservative care and surgery. But aggressive rehab, and this was the work by Saul and Saul in California, that is medical, injection plus stabilization exercises and occasionally manipulation where necessary, gives a 90% relief at 31 months. At 31 months, they still had 90% relief. And that paper was published by Dubourg et al. In Spine 2003. And being published in Spine has sent quite a message to those surgeons that conservative care is equally as good, if not better, than surgical care to the lumbar spine, even in the presence of neurological complications such as muscle wasting. The year 2000, of course, is the new century. Manipulation is accepted by physical therapy. It's being taught in the schools. Research supports its practice, and the profession has mandated that all therapists must learn manipulation on coming into the profession. That's a CAPTE regulation. Now a little bit of philosophy. Clearly there are different approaches to the schools of thought. There are those who treat symptoms. Cyriax, Maitland, McKenzie, Simon. Now Cyriax may have thought he was replacing the disc, but his treatment was based on monitoring the symptoms, the centralization, if you wish. Maitland likewise, reproducible signs. McKenzie, centralization. And Simon. Those who treat dysfunction, Kaltenborn, myself, Mulligan, osteopathy, and chiropractic largely. Of course, in the broad scope of things, everything is arguable, and placing a name or profession in one group, and one group only, is of course contestable. Modern osteopathy, as I said, was founded in 1874, but today is a full medical practice. Modern chiropractic is at crossroads. While most of the schools teach a mixed philosophy, a modern evidence-based philosophy, the largest school or two in chiropractic are still teaching the old straight method of subluxation and adjustment. We've been talking manipulation, but on the other side of the coin and in association with it is instability, because it's tight joints that lead to instabilities. Here's a picture of my yacht being balanced on a rock in Alaska. That's an instability, but it was supported by a wire there. You can see an anchor on top. That's a picture of stabilization in a very inherently unstable situation. We've been talking about instability for years within our philosophy, and we've been giving seminars on the subject. Hypermobility is not instability. These young ladies here are extremely hypermobile, as you can see in their spines. I think they're from Cirque du Soleil. Now, however, what if they became fatigued? I believe those joints would be immediately unstable. So if they overtrained or took time off and lost their muscle tone or were ill for any reason, their hypermobility, which is taking their joints far beyond the natural range, and they certainly are showing great stability here because of their neuromuscular control, but should any of those circumstances arise which I mentioned, they become immediately unstable. Now here's a picture of a disc herniation at an unstable level. You can see the arrows pointing to the disc herniation. You can see the osteophyte on the front of the vertebra just below. That's an osteophyte indicating that there must be an instability. That's what osteophytes do indicate. Here is the same picture now on backward bending. You can see the protrusion has gone further back. And you'll notice that there is a 3-level discogram and a myelogram. The subject is standing. Actually, I confess the subject is myself, and I volunteered to have this done. Now, on full backward bending, after a repeated number of times, you can see that arrow showing the tear, but you can see that much of the disc has become extruded and has moved up behind the vertebral body, between it and the spinal cord, that bright white area. So what we have learned from this study, there's an unstable spine when you develop a disc tear, which I developed by deliberately lifting incorrectly repeatedly. Forward bending will extrude some disc material, backward bending extrudes it further back. This is an unstable spine, but stable because of its neuromuscular control, but osteoligamentously unstable, neuromuscularly stable. So that's the definition that we use. That spinal instability is where the osteoligamentous and or neuromuscular components of the spinal segment are unable to hold the segment either in spinal neutral or at other points in range against creep and slippage and other aberrant motions. Here's a disc that's herniated, clearly showing you a very worn out disc and an unstable one. This is a healthy disc, everything's intact. And you can see the healthy disc has a neurovascular capsule, top left hand corner, and it's fibrous. Whereas you come down the path and then come down the next column, you'll see you finally get to a nucleus. We're looking at a 55-year-old subject, by the way. Not much of a nucleus there remaining, but it's much more gelatinous than the fibrous capsule and outer layers. If those fibrous layers tear, there will be an effort at healing because the outer capsule is vascular, and here we see a blood invasion to try and heal that tear. And these patients need to be treated very well with stabilization activities, to rotate the spine as in a manipulation, or to forcibly repeatedly forward bend and do twisting. That nucleus would herniate out through that tear that is shown there. Other tears here you can see, and you might also notice that over time the annular fibers which circle the nucleus begin to realign across the cartilage end plate to the tear, thus weakening the disc still further. Here's a disc that's badly degenerative, and you can see the blood has invaded it, and in the lower part of the picture on both sides, particularly the right, there is some healing of that disc material. That was a bloody disc, but it is also well innervated and would be a painful disc. The normal healthy disc has no way of conducting pain except from its periphery where it is innervated. But a degenerative disc can become very painful, as nerves will accompany the ingrowth of those materials. Here's a picture of a disc prolapse in the middle of that circle, and you can see it shut down the intervertebral foramen. The prevalence of back surgery in the United Kingdom is 10 per 100,000 people. In Sweden it's 12, Norway it's 12, United States it averages 35, and Los Angeles County it averages 70. Why are we doing from 3 to 7 times more back surgery in America than they are in these other countries where everybody has universal health care? And surely it's because surgeons like to operate, but they are operating, of course, more than they should. Conservative care is equal to or better than surgical care. So there's no way that we can escape the fact that physical therapy is in competition with orthopedic surgery. Orthopedic surgery can at times be rather excessive, as you see here, a 3-level fusion and a 2-level interbody placement of bone to replace the disc. Is all that really necessary? Could not this patient have been better treated by physical therapy in the early stages to have never got so bad that perhaps something like this is required? Surely this is excessive. So, in conclusion, manipulation is now mandated in all physical therapy schools. Chiropractic struggling and fighting for its existence. Orthopedic surgeons are now our biggest competitor. Manipulation is holding up and advancing under evidence-based practice. There is no substitute for patient care based on a thorough and ongoing examination that addresses not just the pain, but the cause of the pain. That is our philosophy. Be aware of the quick fix, the quick way to pain relief. Be cautious with evidence-based, purely on the literature. Not all of it is sound, and much of it will not last. Evidence is a 3-legged stool, remember. The published evidence, your clinical experience and expertise, and the patient's culture. All must be taken into account. Evidence-based literature should not be applied without taking into account the skill of the clinician, the culture of the patient. And be yet more aware of clinical prediction rules that use gross techniques and do not address the patient's individual needs, all in an effort to get a quick fix, a quick relief of symptoms. Patients are on this planet for years. They need a long-term fix. They deserve a proper evaluation and treatment that is directed at this patient as an individual. Remember, only hands-on skills cannot be outsourced to China and India.